And now we are going to jump right into our next presentation on COVID therapeutics. For those of you who are just joining us, I am Dr. Jim Holmes, president of SAM. SAM is the premier international organization representing researchers and educators in emergency medicine. In our work, SAM promotes and facilitates scientific discovery, educational innovation, and professional and leadership development of our members. Today, we are proud to bring you a COVID-19 presentation entitled COVID Therapeutics. During this presentation and during our question and answer session, you will hear from Dr. Paul Auwaerter, the Sherilyn and Ken Fisher Professor of Medicine at the Johns Hopkins University School of Medicine and the Clinical Director for the Division of Infectious Diseases and Director of the Sherilyn and Ken Fisher Center for Environmental Infectious Diseases. Dr. Auwaerter will share his experiences fighting the COVID-19 pandemic, providing along the way guidance and insight that will likely prove invaluable to the rest of us as we care for our patients in our own emergency departments and communities. During the presentation, you may submit questions for the presenters by clicking the Q&A button in your Zoom menu interface. Questions that are upvoted will be prioritized during our question and answer session to start immediately after our presenter has concluded. We also want to recognize several experts that are joining us online behind the scenes and will be helping to answer questions throughout the presentation, including Dr. Andrew Meltzer, Dr. Ryan Lafayette, Dr. Namita Jayaprakash, Dr. Colin Grenadier. Thank you all for your time and expertise. It is greatly appreciated. To begin, I'd like to introduce Dr. Rich Rothman, SAM's COVID-19 Planning Chair, to provide the opening remarks for today's presentation. Dr. Rothman is the Executive Vice Chair in the Department of Emergency Medicine and Professor of Emergency Medicine at Johns Hopkins Medicine. His research program focuses on the interface of emergency episodic care and infectious disease surveillance, diagnostics, and treatment with research on varied commonly occurring ED conditions, including pneumonia, skin and soft tissue infections, sepsis, HIV, STDs, influenza, and now COVID. He has particular expertise in development, translation of rapid and novel molecular diagnostics. At Johns Hopkins, he works with an interdisciplinary research team, including investigators from emergency medicine, microbiology, infectious disease, and public health. Currently, Dr. Rothman serves as principal investigator for the NIH-NIAID Center for Excellence for Influenza Surveillance and Research, as well as a lead on a BARDA Health and Human Subjects Cooperative Agreement to study new approaches to advance therapeutic trials for pandemic response. Dr. Rothman is also one of the founding members of the SAM MTIDE Group, a national network of academic emergency departments focused on research practice and policy on emerging and transmissible infectious diseases. Welcome to you, and thank you for being here, Dr. Rothman.
Thank you, Dr. Holmes, and thank you to SAM for hosting today's COVID session. Soon you'll hear from Dr. Paul Auwaerter, who, as Dr. Holmes mentioned, is a professor of medicine at Johns Hopkins University School of Medicine, as well as clinical director for the Division of Infectious Disease and director for the Sherilyn and Ken Fisher Center for Environmental Infectious Disease. I've had the pleasure of working with Dr. Auwaerter for nearly 3 decades as a colleague at Johns Hopkins. Dr. Auwaerter serves as the executive director of the Johns Hopkins Point of Care Information Technology Center, which produces numerous guides on antibiotics, HIV, psychiatry, and diabetes. Dr. Auwaerter also serves as editor-in-chief of the antibiotic guide that over the last 20 years has grown to be a standard reference for infectious disease-related clinical decision support and rational antimicrobial management. His research and clinical interests include improving diagnosis and care for patients with Lyme disease and other tick-borne infections, as well as surgical infections, Epstein-Barr virus, respiratory diseases, and antibiotic resistance. Dr. Auwaerter is past president of the Infectious Disease Society of America, the largest professional society worldwide related to infectious diseases. Probably nowhere in the history of medicine has there been such a rapid rush to design, develop, test, and evaluate the impact of varied new therapeutics in such a short period of time. Dr. Auwaerter has been leading some of the efforts at Johns Hopkins to evaluate and assess new therapeutic trials. His extensive history as a researcher and national leader in therapeutic trials for infectious diseases gives him the perspective to help us understand this rapidly moving field as we consider current and future therapeutic options on the horizon for patients with COVID. Welcome, Dr. Auwaerter, and thank you for taking the time to prepare these comments.
Thank you so much, Dr. Rothman, and also to Dr. Holmes and your society for the invitation and speaking today. The topic is COVID therapeutics, and I think as many of you know, we are learning so much about this particular RNA virus that we are in its infancy, but really perhaps even at very first steps in terms of therapeutics. But I think I'll try to give you a glimpse as to where we are and what at least over the next few weeks might transpire. But as always, this is such a fast moving field. Thankfully, there'll be many more efforts and so on. So next slide, please. This is my disclosure, long-time stockholder since my aunt suggested this years ago. Next slide. When it started off, I have to say, when this appeared on the scene, many of our clinicians at our hospital were faced with an issue, and that is, okay, there's very little data, but we want to do something for our patients, something more than just supportive care. What can we do? On the other hand, there were people that had advocated, well, we don't know what works really in the way of clinical equipoise. The only rational way we can offer treatment to patients is through a clinical trial. And certainly that's a very valid point of view, except many hospitals, including our own, did not have clinical trials operating. And of course, many smaller hospitals do not have this opportunity. So it was that kind of tension that I think was really fraught and led to lots of conversations and really different points of view as clinicians, whether you would try something for which you are extrapolating from small amounts of evidence, or would you just wait, do the best you can, and wait until there's a clinical trial or better information. And of course, there's arguments on both sides of this, but this was indeed a tension that still continues to this day, just based on the fact that we have so little information and patients are so desperately ill. Next slide. So just quickly, many of you are already familiar with COVID-19, which is a disease name from the SARS coronavirus 2, which is the pathogen. And initially, there's a very robust viremia, even in people that are asymptomatic, but then that tails off. And not everyone, but many patients, 5–10% or more, higher in other risk groups, seem to have not an abnormal, but a heightened immune response. I mean, the immune system quite goes berserk. There's a cytokine storm, which has been popularized and can cause tremendous injury to organs. And of course, the lung had gotten the most press with ARDS before recovery. So there have been many ways that this has been proposed and tackled with the idea that antivirals might work best early on, that if people evolve into severe COVID and the hyperinflammatory response, approaches that quell the immune system are thought to be the way to go there. But of course, we are really only still learning about the impacts of this virus. And, having grown up in New York City, in terms of being a medical student there during the HIV era, in a way, once we sort of identified the virus and knew that it tackled the CD4 cells, it made sense why people developed opportunistic infections. Here, this is a much more confusing virus, I would say, at this stage. So we still have lots to learn. Next slide. Now, all of you think of a number. How many drug intervention trials are there now for COVID-19? Dr. Rothman, you get your number ready. And if anyone guesses it, they win all the jelly beans. Okay. This was just, and this may be wrong because I looked just 2 hours ago. Ready? Advance. 558 drug trials. These aren't all COVID trials. These are just the drug intervention trials. So obviously a stupendous number. Some of these are very well designed trials, others are not, but this is the registry, and that includes the WHO and so on. Next slide. So I think patients and even some clinicians forget this is a viral disease. You don't kill a virus. The virus needs to co-opt a host cell in order to replicate. And if you use influenza as a model, and I know in emergency medicine, many departments have now pivoted to providing antivirals for influenza at early stages, because we know the earlier you administer that drug, the better you are, with the idea that if you can prevent the virus from infecting more cells, you probably will decrease the viral load and the host cell damage or host immune responses that cause injury. Now, whether this works exactly the same in this coronavirus is unclear, but there are a number of interventions, and straightforwardly, I think most people can grasp that antibodies or convalescent plasma, if circulating, would block the coronavirus from docking with the ACE2 receptor, which is the key receptor. I think many people don't realize, though, that this is not sole and sufficient for viral entry. There's a serine protease, TMPRSS2, such a catchy name, that's required for the virus to enter. And there have been strategies with drugs such as Camostat to block that. Now, this is a serine protease inhibitor. It's actually it's approved in Japan for chronic pancreatitis. So it's already been trialed in humans. So it is in randomized controlled trials now, but this is sort of at the viral entry phase. The antimalarials have been targeted as perhaps interfering with acidification and the phagolysosome, which is part of the endocytosis of the virus, and therefore interfering with further viral replication. Protease inhibitors used for HIV have been used very commonly in Asian countries pretty early in January. And we're often part of the routine administration, although a clinical trial, RCT, really showed that this drug failed. It has a very high inhibitory quotient that won't be reached with customary dosing of this compound. Remdesivir we'll spend some time on, is a nucleoside analog, much like AZT was for HIV, which really gums up the RNA replication and protein translation process. Next slide. Now, you've heard of so many drugs. I mean, it's sort of like your Aunt Zelda he said, I just heard about this drug that's going to work against the coronavirus and be a cure. There are scores and scores of these. And in fact, some of these are based on some reasonable in vitro studies that show that if you put a drug into a cell culture with the virus, that you produce less virus. The problem with many of these in vitro studies are many of these agents sicken the host cells. So if the cell culture itself isn't as healthy, of course you're going to diminish making new virus. And the issue there is anything that looks good in the test tube has a super high failure rate once you put it into human trials, because this is a far different process. And the landscape is littered with agents that were thought to work against Ebola or influenza in the laboratory, but yet have not translated in clinical practice. So The menu is very large for study, but probably the candidates that will work will be few. Next slide. So much of what physicians pivoted to here in North America were shaped by the Chinese guidelines in February of 2020, which had this menu here. Some of the drugs we've already talked about, but included anti-influenza drugs, in part because they didn't know if they were fighting flu or the coronavirus, an immunomodulator, which we'll talk about, tocilizumab, and also traditional Chinese medicine. In fact, many of the trials from China, you'll look at the treatments included 3 or 4 of these, often in combination. And so this was all, again, either decisions based on in vitro data or case series. And much of this was adopted by others when we didn't have more information. Next slide. So let's go down the antivirals for a moment. Next slide. I think rightly to start off with Remdesivir. This has been in the news, of course, for many reasons as an antiviral. It's only available intravenously as a prodrug and needs to be metabolized to a molecule that serves as a nucleoside analog. And much like any of those medicines that interfere with RNA replication will inhibit that and therefore pretty much staunch further production of subgenomic transcripts that can then be made into proteins. So a very effective strategy. And typically we think, much like with influenza, antivirals have to be given as early as possible to have maximal benefit. And what's a little different with the coronavirus, of course, is people often aren't presenting perhaps as early with their illness as influenza. Some of that could be education, but really the virus actually proceeds a little bit more slowly than influenza, which can hit you as a ton of bricks within hours and sort of wake people up to call the doctor, whereas this is a bit more insidious and often has already been replicating for a while before producing symptoms. Next slide. So already it might be a bit handicapped. However, this trial got a fair amount of press. It's not really a trial. It's a report of compassionate use of the drug in Gilead for severe COVID-19. And it was 61 patients. And people found it quite remarkable because they said, well, look, 70% of these people needed mechanical ventilation, yet nearly the same 70% had improved with receiving the drug, and 13% died. And so the question was, well, doesn't this look very favorable? And the problem is, of course, there's no placebo arm here. And I think if anyone knows otherwise, I think it's the only time a compassionate use series has been published in the New England Journal. But people were very hungry for information, and it's important to point out the side effects of this drug include liver function test abnormalities, as well as the fact that there are warnings that it has a carrier as an intravenous drug similar to voriconazole that can accumulate in renal failure. So GFR under 30, the drug is not supposed to be used, but we use the antifungal drug, for example, all the time in these settings. So I don't think that would necessarily staunch the prescription of this if you had availability. But this was some of the preliminary information, so people had their hopes up. Next slide. Well, and then later in April, just a couple of weeks ago, this randomized trial from China came out in the Lancet with 237 patients. And this was in the news. You may have heard that it was halted early, in part because they had trouble recruiting people because they were often treated with other drugs or they didn't wish to enroll. And also they didn't see that there'd be much meaningful improvement in terms of their primary findings. So there is no clinical improvement, there is no mortality, and perhaps most disheartening, there is absolutely no impact on the viral load. That is, this drug, which is supposed to inhibit the virus, didn't seem to have any effect in either upper or lower tracts. And this coronavirus does have a predilection for the lower tract, replicating more, probably because there's more ACE2 receptors in the lung compared to the upper airways. There was a subgroup trend, as you can see here, that if patients had gotten the drug earlier, that there was some trends towards improvement, but this did not look very helpful, or at least I should say, obviously didn't have a dramatic effect on outcomes. And this same thing, this is the same argument you've been hearing about oseltamivir, right? I mean, for years, how effective is it? And, you need to give it so early. Does it really have much use after day 3 or 4 of illness, and so on and so forth? Next slide. Now, the trial that clearly has changed behavior is this ACT trial, which is adaptive, NIH-sponsored trial that began in February and is multi-site with the bulk of the institutions in the United States. And we only know press release data yet. This is it. Apparently, there'll be more analysis and publication of results, but this is what we know. That patients were said to respond faster with time to recovery receiving remdesivir versus placebo. And this was statistically significant. Interestingly, this trial in late March changed its endpoint from an 8-point composite score to this length of stay or time to recovery score. So some people have questioned why that was done, although it's been said that even with the composite score, it would have reached statistical significance. We'll wait and see what the data shows. There was not survival benefits. This is what press had said, but honestly, you have here, maybe 92% confidence in this, that there was a mortality benefit, albeit small. How many people might you need to treat here? 26 to 28 people are needed to be treated to prevent death. And was this drug being given as fast as possible? So there are additional Gilead trials that are being sponsored that will certainly add to this. And this trial, next slide, is an adaptive trial. So it is concluded, actually, the DSMB did not do an interim analysis. They actually they enrolled so quickly, they got to the final enrollment and then they analyzed. But regardless, the trial is now adapting and is moving on because remdesivir is thought to be the standard of care, at least from a investigatory standpoint. And so instead of a placebo arm, remdesivir will be the control arm. And now a drug called baricitinib, which is a JAK1, JAK2 inhibitor, which interferes with signal transduction and protein expression within immunomodulator cells so that there's blunted immune responses, will be how this trial will proceed. Next slide. I think many questions have arisen because as this drug received FDA emergency use authorization, this is not FDA approval, of course. It's still an investigational drug. But Gilead had said it would donate 1.5 million doses. Looks like the reality would be more like 750,000 doses. And the initial rollout was very confusing. For example, our 5-hospital health system got a total of 10 vials to one of the hospitals, Sibley in DC, and that's enough to treat 2 patients, for example. So there was, and other centers got none, some got a lot, and no one really understood it very well. There was a lot of criticism. Advance, please. So as of a couple days ago, there was a change from the US government that it will now be shipping to state health departments for allocation. But I think there's still questions as to how much will be available and received. Estimates are that there might be enough to treat 70 6,000 patients or so, but there's both a 5 and a 10-day regimen. Some institutions are thinking of only giving it for 5 days to extend supply. Next slide. Moving on, another antiviral is something from the old hepatitis C playbook. Remember when we made patients very ill, giving them interferon and ribavirin? So the strategy here was the same in this trial from Hong Kong that was published recently in the Lancet that used interferon beta in combination with a protease inhibitor and ribavirin, with the control arm being just the protease inhibitor. And you can see there, the endpoints were simply as a phase 2 trial, time to nasopharyngeal swab negativity. Next slide. The findings here on a 2-to-1 randomization protocol were that enrollment was by 5 days as a median, but interesting findings. The viral carriage was reduced by 5 days. You can see here 7 versus 12 days average there, with a fairly robust p-value and confidence intervals, though somewhat wide. And faster alleviation of symptoms with a 4-day improvement. So you're tracking something close to remdesivir here. And what they used was something called NEWS2 as sort of a clinical amalgam of symptoms, but that's how they rated this and determined that those in the combination group. Adverse effects, as you might imagine, were nausea, diarrhea. They said there was no difference, which is hard to believe with interferon. And there was not a true placebo arm. I think many here are whether this can proceed, it needs a larger trial, of course, but one of the key difficulties with therapeutics are we don't know who's going to proceed to severe COVID. We might have some ideas like the very elderly, for example, those with comorbidities and so on, perhaps patients with obesity and some of the other groups that seem to be hospitalized at higher frequencies, dying more. But on an individual basis, we really don't know. So the question is, are you going to give a drug when people are feeling crummy that's going to make them feel much more crummy? And yet we still aren't sure if there'll be endpoints avoided, such as mechanical ventilation, mortality, and so on. So I think this remains reserved, but is potentially promising, and I'm sure this will also be studied in combination. Next slide. The antimalarials. Yes, hydroxychloroquine and chloroquine, I would say, still being used in many hospitals. Others have stepped away. The long and the short of it is that there is not yet any compelling reason to use it or not use it. I'm not going to go through all these trials. Many of them were early on that influenced people, mainly from the French studies by Gautret, that suggested there was a much more potent decrease in viral shedding with the use of hydroxychloroquine, and especially if combined with azithromycin. The two studies at the bottom pointed to toxicities, the Molina and the Borba, whether using these drugs, which gave people some pause. Next slide. This study was published in JAMA earlier this week and was mainly the New York State experience in 25 hospitals, a retrospective series. Again, this is the kind of data that just makes you stop for a moment, because I was told back in my younger days that you would never really want to make treatment conclusions based on retrospective data unless if you had massive numbers. Here you have, though, 1,400 plus patients. It is, I think, the largest trial experience that's reported. It's not really a trial, it's just a study experience. And what you can see here is that both hydroxychloroquine and the combination with azithromycin scored higher on mortality. And again, another cause for pause. There certainly was not a trend or evidence of benefit. The azithromycin, the neither drug arm and the hydroxychloroquine arm on this graph are superimposed, so it's hard to tell that there's actually 4 lines. But I think this is the kind of information that, if anything, just gives people pause about giving it, especially in patients that are more ill. Our critical care specialists have elected early on not to use it in any of their patients coming up to the intensive care units because of cardiotoxicities. And although many people had prescribed it or in combination early on, I think those numbers have decreased. Although the drug's still being used, we still don't really have quality information regarding it. Next slide. And the safety concerns have been growing. The French have always had a pharmacovigilance study and going across their entire country. And for example, in March, 43 of their 53 cardiac issues were traced to either hydroxychloroquine or the combination with azithromycin. And then the VA study, again, retrospective, got a lot of press because it looked like those that received hydroxychloroquine or the drug with azithromycin were more prone to die, including after when they were on ventilation. Of course, all the caveats go with retrospective analyses, because maybe the more ill patients initially were given this drug, when perhaps if they're suggested to you be effective as antivirals, they should only, if they do work, it may be best in the modestly ill. Next slide. So a meta-analysis that was released earlier this week looked at the available studies that passed at least some muster for a meta-analysis, and basically found that there was really no information yet that it could endorse or refute use of these antimalarials. The same conclusions have been reached by the NIH and the Infectious Diseases Society of America, that there's not good information one way or another. But I do think the toxicities are causing people to give some pause. I will mention that there are federally sponsored NIH trials afoot for both using hydroxychloroquine or the combination with azithromycin for treatment in hospital, also for treatment in outpatients, hydroxychloroquine, and there's also a prophylaxis study which is being run out of University of Minnesota. So we should have some quality data on this combination moving ahead in the next, hopefully, summer or fall months. Next slide. So moving into illness and people with severe COVID, which could certainly have reduced oxygenation on the basis of only the viral effects, it's really the hyperinflammatory effects that seem to cause the most grave damage and get people on mechanical ventilation or even ECMO. And these are characteristic by intense inflammation. We see very elevated levels of inflammatory molecules generated, such as ferritin, C-reactive protein. There are elevated D-dimer, and then interleukin-6 is elevated, not as high as might be seen in conditions such as CAR T-cell cytokine release syndrome. Probably an IL-6 level of 80 appears in at least 2 papers to correlate with severe COVID disease, which I think other studies hopefully will look at. There's still no one clear discriminator or combination for predictors, but this is sort of the landscape. And then, although the lungs got all the initial press because it is a respiratory illness, it's clear that when you're in this severe COVID phase, that all organs can be affected. Next slide. And the lung, though, got the highlight, and many of you are familiar, of course, with ARDS. This isn't usually a common presentation in the emergency department, but rather evolves after presentation. But characteristically, with bacterial sepsis and others, this is a disorder of activated neutrophils. and tissue injury and so on and so forth. But this is not this kind of heterogeneous disorder, at least this sort of common understanding is not how this coronavirus causes ARDS. Next slide. Rather, it seems to be following the influenza playbook. And the influenza playbook is that a small number of patients do develop ARDS, even as the viral carriage decreases with intense inflammation, elevated IL-6, and appears to be a disorder of T regulatory cells that just, cause this intense cytokine release and inflammatory syndrome and subsequent tissue injury. And of course, once tissues have been injured sufficiently for a period of time, it's not clear that anti-inflammatory mediators are going to be effective. Next slide. One that's been gathering a lot of press is the fact that this virus appears very commonly to cause clots. And it's not exactly clear why, but the coronavirus clearly docks to the receptor on endothelial cells, which of course do line blood vessels. And there's elevated D dimers, other factors here, as well as something that seems in some patients to mimic TTP with an acquired Adams 13 deficiency, or even elevations in lupus anticoagulant. These seem to at least be the current characterizations. Next slide. And here's just some selected papers showing very high rates of clots, such that many, especially in the ICUs, are going to high intensity anticoagulation. And I think there'll be even more papers showing, if we look, you'll find more clots that aren't yet clinically identified in patients once they're in hospital. The one that struck me, I think, especially was the Italian study, which was large, but look, that 50% of the clots were identified in the first 24 hours. So this can be a very early phase, although of course Italy had, I think, one of the more severe the population is more prone to severe COVID disease. Next slide. So moving to plasma and immunotherapies in closing here. Next slide. This has been proposed as treatment based on a lot of history where these treatments do work against a variety of viruses that you see here. Next slide. And was trialed in the original SARS epidemic here. And although not a very large study, as you can see, advance, please. Those that got the plasma treatment on the early side, and for example, before they had antibody development, but yet still had positive viral carriage, fared better in this analysis. Next slide. So this has been proposed. In fact, in late March, the FDA authorized an emergency IND. Although the FDA was not supplying the plasma, it was up to the clinician to find it. The trials at the moment include both early treatment, including in outpatients, which is actually being spearheaded here at Johns Hopkins, but is multi-center. Treatment of hospitalized patients, including the ICU, which is part of this expanded access, but the Mayo Clinic is accumulating data as a coordinating center for those that wish to input data, as well as prevention. Next slide. Now, everyone thinks, oh, well, this is direct neutralization of virus, but especially with those that are getting the plasma later on, there's been issues whether, for example, it merely is working like IVIG in this later phases where viral titers tend to already be declining, or doing some sort of other immunomodulation and impacting the hypercoagulable state. Next slide. So there's very scant data to date. Here's three small series that say everybody improved. I don't think anyone publishes bad results early on, but these are the three. and it all looks like, gosh, this is what this is duck soup. This should work, but let's wait for the trials. I would say this is still an investigational approach. Next slide. And here are the risks. I don't think we'll necessarily start infusions in the ED, but maybe at some point in the future, or study enrollment. But there are all these risks, although some are very small, such as trally. And of course, patients in heart failure can have volume overload. The others, I think you're all familiar with any blood product administration. Next slide. Now, the immunomodulators, anti-IL-6 therapies have gotten a lot of press. One was sort of shut down because there were negative outcomes in the severe COVID disease, but actually looked like it helped in patients in the critical group in the ICU. So this drug trial adapted and was changed. So we're still waiting for further data and results. Next slide. Tocilizumab, which is an IL-6 receptor blocker, has gotten a lot of press and use, actually, although it's, of course, quite expensive. It was approved for conditions like rheumatoid arthritis. Blocking IL-6 and subsequent signal transduction to foster additional inflammation. Next slide. And it's these kind of testimonials that I think have given it some popularity based on anecdotal evidence. This is a colleague from Hong Kong, where you can see 1 day after administration, this patient markedly improved. And it's hard to imagine that this viral disease would really improve on a dime spontaneously. And this is other Lazarus-like situations in critically ill patients has also been seen and discussed regarding convalescent plasma. But I think we'll just have to wait for larger trials to really understand its worth. Next slide. One hopeful sign was this French study that said, oh, this drug does improve outcomes and with moderate or severe COVID disease. So this seemed very hopeful, but then there's been silence. And in fact, a colleague of mine who lives in Paris pointed out in the French papers this, which he translated from the French. Next slide, or advance. According to the French press, in this study, the entire DSMB, the Drug Safety Monitoring Board, resigned. So, I think with the rush to publication and so on, I think we all have to be very cautious interpreting results and trying to do what we can to see if they can be trustworthy. Next slide. Now, the NIH has published guidelines. This is sort of the what I would say they're extensive. They deal with pregnancy and others. These are just in the interest of time. I thought I would just highlight, much like the EUA for Remdesivir, it's only for severe disease. You do have to have lower oxygen readings on room air or be on supplemental oxygen, mechanical ventilation, or ECMO. The antimalarials currently are only recommended in context of a clinical trial, and based on the Borba study, they recommend against high-dose chloroquine, which is a quite limited supply in this country, actually. IVIG, and this is not the convalescent plasma, but just straightforward immunogammaglobulin, has been recommended only in a clinical trial, and insufficient data for using IL-6 inhibitors. Next slide. And of course, those guidelines are going to be updated regularly. And as I mentioned, all of this hopefully will be improved in terms of its amount of data and how we can help guide patients. But I think there's already a palpable sense that, early on in a rush to do something, we hope we didn't harm our patients. And I think that remains a very clear consideration, that we do not wish to do that. And all these therapies have that potential. There are numerous trials afoot. Remdesivir, I think, does have promise as an early agent. I'm hoping that there'll be oral nucleoside analogs that might work. Some of those are under study. And of course, the earlier you use it, I think vaccines are in the distance. And so we're looking for therapies, not only plasma, but even some monoclonal antibodies that I think hold some promise. And in terms of immunomodulators, I think people giving it latent disease after the tissue injury, the horse is out of the barn. So it probably is best given earlier, but we still await studies to really refine this information. Next slide. Oh, back one slide. Rich, that's everything. And this is by no means comprehensive, but hopefully was helpful with some of the highlights.
Thank you very much, Dr. Auwaerter, for this timely and insightful presentation. In a few moments, we will answer questions from the audience. As a reminder, for those who are attending the live session, please send your questions in via the Q&A pop-up window by clicking the Q&A button in your Zoom menu interface. We will try to get it to as many questions as possible in our remaining time. So while the questions are coming in, I would like to ask, what, in your opinion, is the most promising therapeutic modality that we know of right now for COVID-19?
Yeah, the crystal ball.
Yes.
Yeah, the crystal ball, my crystal ball is probably going to be wrong. But clearly, I think nucleoside analogs have a role if taken early, I think, in all likelihood, if it's safe. But otherwise, I have a feeling it's going to be monoclonal antibodies that might be able to be generated in sufficient numbers, in addition to convalescent plasma, if the early trials do show promise there, that I think will give some hope, because I think as we loosen social distancing restrictions, the fact that we don't yet really know that we have great treatment makes everyone very nervous, and we don't have a prevention yet strategy. So those are the two that I think, although there are, other candidates as well, but based on the very limited evidence so far, I would say those are the two avenues that seem most promising.
Thank you very much. We will not hold you to that, though.
Thank you. I appreciate that.
But let me ask another question. Is this disease somewhat like cancer, where the standard of care is essentially now being in a clinical trial?
Yeah, so many have argued that. In fact, when Ebola broke out, many people tried experimental therapies, and there was a very, I think, pointed set of conversations saying the only proper way, given the emergency, was to try to proceed with a study, a trial, because we don't know if treatments are helpful or harmful. And this is really the only ethical approach. And I think the tension, as I mentioned before, is when you don't have trials available, do you as a clinician feel like you should just try something? It's that old admonition that I tell medical students: just don't do something, stand there. That standing there may be better than doing something, but in the great American way, people feel better in control by doing something. And I think that's a hard impulse to fight.
Yes, thank you very much. That is very true. A question from Armin Nauruzapur. Any thought on the Japanese antiviral favipiravir?
Yeah. So this is an anti-influenza drug, and has had some interesting in vitro data, and has been discussed as potentially helpful. I don't believe there's been quality data yet. It may work a little differently than our current FDA approved drugs. Oseltamivir probably shouldn't work, because that works on a neuraminidase molecule, which is really not present or needed for this infection directly. And baloxavir, which is a new anti-influenza drug, is a NCAP endonuclease inhibitor, which also probably doesn't work. But the Japanese drug is just a straightforward mRNA RNA polymerase inhibitor, so may have some role. So we'll see. I mean, that's something I think in the next month or two we may hear more of.
Yes, thank you. We'll look forward to that. A question from Mario Rugna. Which is your actual suggested therapeutic option for the early, moderate, symptomatic COVID patient?
Yeah. Well, right now, nothing. I think it would be supportive care. You wouldn't qualify for Remdesivir under an EUA. Enter a clinical trial if it's available. You know, most people do well with supportive care. I mean, fortunately, they're very high-risk people. We don't know who's predictive, but those would be my recommendations. I would say we have used tocilizumab off-label for patients, and we have some indications that it looks like it might be helpful. But again, this is in an uncontrolled environment. Very hard to know how we're choosing these there. So perhaps using a drug that's inhibits inhibits IL-6, I might consider. But again, it's still based on very slender data, mostly case series or anecdotes, which always makes me very uncomfortable. But I'm not quite as, I guess, as dogmatic as those that say absolutely only an RCT, especially if you don't have access to anything in your system. But I think your patients should clearly know the risks and the benefits.
Certainly, thank you. A question from Karen Rhodes. Any thoughts regarding the Kawasaki-like illness in children that has recently garnered significant publicity?
Yeah, we don't know if it's like garden variety Kawasaki yet, or at least I haven't seen that. I'm not a pediatric ID person, but that's Kawasaki's has always been thought to be triggered by a virus or occasionally by respiratory infections. So this seems no different, whether it's some variation. It's interesting, of course, that children generally have not been severely ill and was not really described in the early China experience, but we're seeing it in Europe and North America. Speaks to perhaps some genetic differences. We don't know yet. But this is yet another fascinating aspect to it that does give some pause. And we have to see if the treatment for Kawasaki's is the same, interestingly, for this disease, although I suspect it probably will at least be viewed as such. So, yeah, no, I mean, all I can say is this virus continues to amaze me as we learn more and more as we move along. Think about where we were 3 months ago, 4 months ago, thinking this was pretty much an influenza-like illness, and where we are now. This is not influenza.
Yeah, very true. A question from Marco Silvilati. Your thoughts on the limitations of using viral RNA shedding as a surrogate endpoint, and how to interpret the findings of trials that rely on this measure as an indication of efficacy?
Yeah, so I think it depends on the trial. Raising a very good point that we know that at least data that I'm aware of from people that are not that ill, the virus can shed for 3 or 4 weeks, right? So that doesn't mean they didn't improve and so on and so forth. Now, it is a surrogate marker, and if you can generally turn off the virus early on in the first days of illness, I do think it's important. Whether it's important at day 14 or 20, I think it's less so. There's just probably less impact there. And again, I hate to keep bringing up influenza, but those are the quality studies I know. You know, for example, oseltamivir given within 6 or 12 hours of onset of symptoms, people improved by 3 to 4 days and had marked decrease in viral carriage compared to those that took it at 48 hours, for example. So I do think it does have a role. However, I'm much happier with clinical endpoints, whether it's mortality, whether it's mechanical ventilation, even length of stay. Any of those to me are in this disease at this time frame more important than just viral carriage. But that's much easier, and why you got so much press and why hydroxychloroquine and azithromycin got a lot of traction early on based on very small numbers of patients, like 6.
Yes. One final question, I believe. What is your current practice for patients that are stable enough to be treated as an outpatient? Is there anything beyond supportive care for these patients?
Yeah, unless if you're in a clinical trial, I'm not aware of any outpatient recommendations. Certainly, you would not qualify for Remdesivir under the EUA. There are clinical trials looking at the ambulatory population or the less ill population. So if you are in an area, that may be an avenue to seek. Again, you don't know if you're going to get the active arm or not, but would be helpful to try to understand what we can do for our patients. So I always encourage people at this stage to enroll. And there are increasing numbers of centers now that the panic and pandemonium and chaos that really we were all grappling with early on is now a more organized chaos. And we're doing, and I'm sure as Dr. Rothman and others will testify, we're actually launching studies and enrolling patients when that was not the case in March.
Yes. All right. That is the last question we have time for today. Thank you again to Dr. Auwaerter for sharing your incredible stories and for helping the rest of the country prepare just a little bit better for the COVID-19 pandemic in their own EDs and hospitals. Dr. Rothman, do you have any final remarks?
I just wanted to thank Paul for the time that he put in and putting everything in perspective for us in the emergency department. There's obviously a lot going on. I think from an ED perspective, like Dr. Auwaerter mentioned, I think there's opportunities and important roles we can play in emergency medicine, partnering with our and critical care colleagues going forward as some of these trials take off, both from the inpatient side and the outpatient side. I think there's a lot of excitement in terms of being able to potentially make a big impact on a disease with a high morbidity and mortality. And I think from the standpoint of us and the society and us individually in our own academic centers, I think we should look for those opportunities to participate, both to help with individual patient care as well as for the health of the public. So thanks again, Dr. Auwaerter, greatly appreciated, and no other comments.
Well, and thank you for listening. I want to thank everyone for really being at the tip of the spear here in terms of all the patient care and work with this pandemic. Thank you.
Thank you very much. It's our pleasure to have you speak today. Thank you again to all of our speakers and to all the viewers for joining us today. This concludes our keynote address and special COVID session for today. In a few moments, we will begin our plenary abstract presentation on SAM's YouTube channel and Facebook Live. We hope you will join us there now. Thank you very much.